Professor Frank Chang to present his lecture about reconstruction application of facial fat grafting. Professor Chang, please.
Yes, thank you, Professor Lee. I have talked about a lot of cosmetic application of facial fat grafting. Today, in contrast, I was talking about reconstruction application of facial fat grafting. I have no conflict of interest. I must borrow the word of Dr. Kensaya, say many of my myriad technique I became skilled as I work to improve appearance of my cosmetic patient has the direct applicability to reconstruction surgery. That's true that I learned the fat injection mostly from cosmetic patient, and I apply to reconstructive surgery to improve the outcome of my patients. My favorable donor site is still abdomen. I would like to puncture inside umbilicus. This will hide the scar. When I go to Japan, my teacher, Dr. Yoshimura, he liked to puncture in the inguinal area. Still, I prefer the umbilical puncture. In 2008, PIS Pardoni published a paper showed that the lower abdomen has highest cell concentration. The second one, highest concentration of fat cell is inner side. We want a more viable cell so that survival might be better. Another study, Grace's published in Aesthetic Surgery Journal, say that abdomen might have higher soluble factor, that's a hormone, compared to inner side of knee. But I use abdomen just more convenient, not for those cell concentration or soluble fat. Another paper say multiple small hole brown tip cannula better than single 3 millimeter hole cannula. There's one side I like to use 3 hole cannula one side, so I can control liposuction up, lateral, or down. This is the old method. However, I feel that the pressure is too high. So I invent this, that this apply can gradually pull the syringe backward. This is the first one. Then you can see with low pressure, the fat is become more beautiful. This is the second one that I fabricated. But however, I go to Japan, Yoshimura say, why so complicated? You just need a wall suction, that's enough. That's all you can need. So right now I just attach it to liposuction machine. Just don't open up the pressure to the end. Later on, to speed up the surgery, cause my surgery become more and more. So I use micro air. And there's one paper published in JPLOS 2014 showed that the power assisted liposuction, so-called micro air, has comparable viability and the differentiation compared to the manual aspiration. So This one can speed up your surgery and more smooth abdomen because this vibration will help you out to smooth the abdomen. Centrifugation is still the most frequent method used, so-called gold standard. Yoshimura published this paper 1,200 G for 3 minutes. We have the new centrifugator. Before we use PRM, but right now we use G, and the new centrifugator has this G, so we just have to grading for 1,200 G for 3 minutes for better ADS-C survival. And if the amount is small, then I prefer use cotton gauze. And there's a 4 paper published comparison of centrifugation show better or equal effect. However, I must emphasize that centrifugation is still the gold standard. Yoshimura like to use a sharp tip 16 gauge in breast. However, in face, strongly advise 18 gauge or 16 gauge brown tip because the open up is lateral, so that the intrusion pressure is not so high. This could avoid vascular accident. Dr. Coleman published in Aesthetic Surgery Journal 2002 under avoidance arterial occlusion from injection of soft tissue filler, and showing that the brown tip and 18 gauge is better in the face. And more currently we use the mouth gun because the every shot is 1/60 or 1/240. The intrusion pressure is so low, so it's almost impossible that you puncture inside the artery, push the fat, and the retrograde go up to the original side, cause arterial occlusion. This is my cosmetic patient. You can see before and after surgery. The panfacial fat injection has advantage of facial rejuvenation. It's not only fill up the depression, but also correct the age stigmata, but also we can fill up the nose. And you can notice that the nose after fill up, this is permanent. You can have nicely look nasal dose. For the frontotemporal area, I always like to start from zygomatic arch because on the point 2 here, there's a lot of vessel. Before I enter here and cause a lot of ecchymosis. Right now I puncture here. Then the first plan that I inject is just above the temporary fascia. You just enter your needle 45 degrees, touch the dense temporary fascia and advance it. This could further avoid bruising. And the injection area is above temporal parietal fascia. Before I inject inside, however, this temporary muscle, if you inject inside the muscle, you just imagine that that's a poor immobilization because every time you talking, you chewing, you are using temporary muscle. And then you put the graft in a very mobile area that will end up with absorption. This is my cosmetic patient. You can see with the feeding, the depression go away, and the depression lateral view, you can see convert a very beautiful curve. So this lady, long time ago, was referred by Professor Chang. She has several times with hyaluronic acid injection cause irregularity. She is very upset about feeling again. Her mom brought her to me. This is the first injection with overcorrection, 20%, a small margin. However, in 1 week, I noticed this depression because she liked to use her corrugator a lot. Immobilization is very, very important for graft survival. If you put it a highly mobile area, will end up resorption and the irregularity like this. So on the second time, when she came back again for second feeding, I start to use Botox 1 week before the surgery, and you can see the feeding after the surgery. And this become better. You can see the survival become better. Then the third time I combine with laser. And if you can notice that perilumbar disease, after you feel out the depression, always hyperpigmentation. So the pico way might help. You can use 1064 mode or 523, but personally I prefer 1064. This will gradually erase her hyperpigmentation. Then this is the final 4 years follow-up, and you can see the improved facial contour, and she come back for the laser treatment to has better coloring much. I noticed that Botox could polarize frontal and the corrugator muscle, and so that you can reduce the tension around frontal area. I always like to mention this patient. I do the sarcoma reduction, angle resection, genioplasty, elongation genioplasty, fat injection for entire frontal area. But under explosion, because the traction is so high, so the patient come back with frontal branch paralysis. And she did not know that because I explained that I do the Botox injection over frontal for cosmetic procedure. And I told her maybe the dosage is too high. You can see why she smiled, the arc of the eyebrow is still the same. But the paralysis come back, the movement come back in 1 year. And you can see very good survival and a very good contour. So that this give me a emphasis that if you have good immobilization, better fast survival, and the frontal area became more regular and more beautiful, then we publish this in annual practice surgery. Then come this gentleman again. After 2 times of fat injection, still coming with depression. This gentleman is so upset. So I do the first time fat injection together with Botox injection. This is the second time. And this is after surgery. This is 1.5 years after surgery. You can see very good contour. And the patient is very, very satisfied with 2 times of fat injection. We can use for the temporal hardening after cranioplasty. And you can see this gentleman still the scar has defect. But if we inject very superficial, then you can fill up the depression area safely with the fat injection. And this is after surgery. This lady has a small tumor, very superficial around this area. And she told me that if this will cause a scar or depression, she'd rather not have the surgery for the cancer. So I do the endoscope to remove the fat, remove the tumor. And the same time, I do the fat injection to smooth the contour. And this is 6 months after. You can see there's no depression at all because in the first instance, I do the fat injection. Upper orbital harrowing is one of my favorable sites for cosmetic injection because the patient was satisfied so much. This lady has upper orbital harrowing. I do the fat injection, left side and right side. And if you can see the scar, if you do tiny fat injection, this is one of my early case. I was not so aggressive, but you can still see the improvement of scar. Later on, I attend a lot of fat injection meeting, and everybody talking about fat injection, edible stem cell, derived stem cell can improve the scar and can soften the scar. This young lady has trauma while childhood, and you can see left side harrowing. I do the fat injection. 2 years follow-up, you can see the fat is still there. I do a lot of nasal dorsal augmentation with fat. And we publish in annual practice surgery, so-called minimal invasive rhinoplasty. This young lady has hyaluronic acid injection nasal dorsal, get infected and get a depression like this. It's very ugly scar. Then this is the first fat injection, second fat injection, and you can see you can reverse the nose and you can soften the scar, and surprisingly, without any days, the hyperpigmentation get improved. This young lady has rhinoplasty. After remove prosthesis, she has a depression right over nasal dorsal. Then I reverse it with fat injection. This is lateral view. Still, we can increase the nasal dorsal height. In 2011, we published this pure dice cartilage rhinoplasty. And on 2020, we published this so-called a la cartilage using inner curve of rib to reconstruction nostril shape. And we received the comment from editor. So we write a letter to editor and publish on 2021 on PRS, talking about the need of a la cartilage. And on 2021, we published in CPCJ calls this viable cartilage can unite it with dense fiber tissue, and you can really bend your nose after the surgery. And one of the most frequent complications from this procedure is dorsal irregularity. Happen to 7% of our patients. Like this lady, initially you can see nasal dorsal very smoothly augmented. And last week we talking about grafting with the fascia graft. It's difficult to obtain a very fine union from the grafts. You can see pure cartilage has no problem with this. However, you can see dorsal irregularity after surgery. Then I told the patient to massage. You can see some improvement. However, still the nasal dorsal see some irregular. On the second stage, we do a fat injection rhinoplasty. And this is a small waving to the inverse U again to suture is backward. And this is the 4 years follow-up. You can see the fat injection straighten because I feel out the depressed area and the straighten the nasal dose, and this is long term. We can use for the upper lip augmentation. This is a hemangioma case. We can inject very superficial to augment the lip, not only the lip, we can do the definition of columella column. And I found that the definition of columella column, so that I developed this. Like this patient, the scar is not so obvious. The only thing, she has a slightly depression over the cleft side, and the feature color is more flat compared to the normal side. So I just do the fat injection. You can see very superficial fat injection. You can cause a bulging of feature column. And then the normal side, I always inject a little bit so that the central dimple can be accentuated. By the same time, I do the nasolabial 4 injection, tear through, and the temporalis, and that is 1 week, 2 weeks, still bulging here, 1 month, still bulging, 1.5 months, 1 year, 1 year half, and the 3 year follow-up, you can see the bulging still there. And this is 5 years follow-up, still the bulging there, with only once the fat injection. This lateral view, not big change. And basal view, you can obviously see the scar depression be reversed by the fat injection. And then we study on the fat injection of feature column, especially for the patient if the scar is not so obvious. If you open it up, the patient has hypertrophic scar tendency, then you will end up with hypertrophic scar chance. That happened in our past review. Our case is almost like 2%, 1 to 2% has hypertrophic scar. So you can avoid the hypertrophic scar just with fat injection. And this is accepted by PRS this year. This scar dimpling, she has hyaluronic acid several times, and you can see just reverse it with fat injection. This young boy with perilumbar disease, you can see a slight depression, feature column, free border, and the nasal dorsum, nasolabial 4, and a slightly depression over frontal area. Then I just do the fat injection here, the depression area, nasal dorsum, and here I do composite ear graft to download the ulnar retraction and the G-plasty here and the fat injection after G-plasty. And this is the end result. Not perfect, but I think it's acceptable for minimal invasive. You just put a cartilage graft here, fat injection to reverse the depression, upper lip with fat injection, and the frontal fat injection. This young lady has a facial trauma by the golf with facial bone fracture. After the reduction and the resorbable plate fixation, she still complained the depression and the scar here. So I do the fat injection only. You can see how the scar remodel and get improved over time. And this is 1 year half follow-up. You can see the scar go away, the depression go away just with fat injection. This young lady with left side sarcoma fracture. She told me because she come after 1 month after the trauma, and the emergency doctor did not find out she has fracture. And when she come back, she told me, doctor, I like my left face compare more than right face. I said, huh? But regular way is to do the reduction. She refuses. She want a reduction of contralateral side. I say I can try. You can see here is the impact left side depression, but she like this face. So I do the CT image, do the mirroring. The difference is almost 7 millimeter, 0.7 centimeter. The safety reduction is 6 millimeter. So I told her that I will do 5 to 6 millimeter reduction on the normal side and do fat injection on the contralateral side. So this is the depression area. I will do the fat injection. And this side, I will do L-shape sarcoma reduction. And then the segment not only pull in, but also pull backward. So that I fix with the plate and the fat injection on the contralateral side. After the surgery, you can see symmetrical face is achieved. And this is 1 week, 1 month, 6 months, very symmetrical. And 1 year, you can see better symmetry over both face. And she's satisfied with that. And we published in Aesthetic Surgery Journal 2016. Then come to this gentleman who is very depressed. I think this is another variant of perilombar disease, because he told me that after 11 years old, this face gradually go downward. But surprisingly, the mandible is in reverse, go very big. And I do the mirror image again, the CT image. And the difference is more than 1 centimeter. It's almost 50 millimeter of difference. I told him that there's no way that I can do that except level one advancement. Like this, the entire block advances, but this is big surgery. And a lot of problem if you touch the orbital. Then after discussion, we will try maple augmentation. Then I borrow our Professor Chang's technique. What is that? 3D carving. We use the block of maple, and that broken maple, we can obtain 9 millimeter thickness, and we carving this into fit to the area that is depressed, and the junction area will be smooth using fat injection. This is immediately after fat injection. This is 1 month follow-up. You can see very nice contour, and still you can see very nice contour. Even he has a little scar retraction over lower eyelid. However, he is quite satisfied. And this is using the Professor Chang's 3D carving technique. And you can see very beautiful smile, the fat bulging, and it's similar than the contralateral side. From this gentleman has trauma, has surgery on right side, while childhood end up with right side atrophy and the facial deviation. We do the orthodontic surgery long time ago. On that time, I did not incorporate fat injection together. You can see after the surgery, there's a depression here. So I very carefully do almost the same contour of fat injection. However, if you do more than 4 millimeter of fat injection to contour, will end up like this gentleman, the fat go downward. You can see on the right lower mandibular border has a new margin. This is because of the gravity. Our gravity pull the fat downward because you will have extra fat the right side. And this is 4 years follow-up. You can see the small margin still there. Look again, the initial fat injection is very symmetrical. However, with 4 and 5 years follow-up, the gravity pull the fat downward. So come this lady, perilombar disease. I noticed that no longer I can do so much fat injection. So I need some bone graft to augment the depressed area. So this patient has frontal depression, parafrontal depression also. So I will do fat injection, double ID, single ID on the affected side, I will do again. And the sarcoma reduction on the contralateral side, this is then from Professor Lowe's hemimicrosomia. He presented once that he will do sarcoma reduction or contralateral side, and the upper lip atrophy will correct it with fat injection. So sarcoma reduction, remove of back of fat pad of non-affected side. Then fat injection and interposition bone graft on this side to augment here. And this is after surgery. 3 months, 6 months, the fat get resolved. However, you can see the upper lip get some improvement. Then in 1 year, we go second surgery to do the second fat injection. Again, augment the lip again, resuture the upper orbital again, and all touch up again. And this is 6 months of follow-up. 1 year, 2 year, 4 year follow-up, you can see the improvement. And again, you can borrow the advantage of fat injection, that is improved skin quality. You can see the rejuvenation effect of our fat grafting. And this upper lip has been augmented with fat injection. And if you pay a close look, the affected side, the QB ball has downward using just fat injection to pull this QB ball downward. And again, the upper lip fullness is reversed with fat injection. And this is 3/4 view, lateral view. This young lady with right hemifacial microsomia. And you can notice this while she grew up. And when she reached to teenager, Professor Ren Zhongjuan do the ear reconstruction first. This is the ear reconstruction with Professor Ren Zhongjuan, 2 stage with recollage with very, very good result. And then on the second stage, I go for orthodontic surgery. And I would like to use all the cosmetic orthodontic surgery for her. That means not only the occlusion, sarcoma reduction, 5 millimeter the set. This is level 1. Sarcoma reduction, double ID first, nasal dorsal augmentation, and we published with Dr. Ronick in CPCJ 2021, simultaneous fat injection for nasal dorsal, and with the published craniofacial surgery, simultaneous nasal dorsal double ID. With orthodontic surgery, and with Lonick's publication, the survival rate is better because after surgery, the patient has great immobilization and the normal baric oxygenation. Because normal baric oxygenation could improve the survival. And I think everybody know that Yoshimura did a study, compare hyperbaric oxygenation, normal baric oxygenation, show the normal baric oxygenation will improve the fat in survival rate. And after the surgery, the patient always has normal baric oxygenation using T-tube. Then this, I told you with the previous case, that so-called interposition bone graft. In between the proximal segment and the distal segment, I put a bone graft. And this one has almost like 3 to 4 millimeter augmentation of the lateral chip per hour, so that the fat injection will be less. And I learned from previous experience. So this time I do the fat injection higher. You can see the injection is higher compared to the normal side because it's fat descending. I do a small puncture because I need transcortical screw to fix the bone graft. And we published with our dentist, Dr. Wang, on PRS 2017, show that simultaneous fat injection in facial asymmetry will improve the lower facial profile index. And Dr. Denadai in PRS 2022 is a simultaneous medial chip fat injection will augment the medial chip, and the patient will look younger and more beautiful. So I use all the cosmetic procedure on her. You can see this is just one procedure, and this is after fat resorption. And this is long term, 1 year and a half. She still complains that this side is smaller. However, if you can see after the fat descending, the height becomes symmetrical. If we go back to the intraoperative side, the fat is injected much higher compared to the normal side. And you can see after the descending, this became more symmetrical. On the second stage, I do the second stage fat injection and resuture the upper eyelid again, and she became like this. This is 3 months after second fat injection. And the medial cheek, you can see nicely projection of medial cheek, fat injection, and the symmetrical face using fat injection together with orthodontic surgery. Again, bone is brick, concrete for me. Fat is our cement. Other cosmetic procedure is like a painting. Then together we can build up and painting up a very beautiful house. And I am very proud to be part of Craniofacial team. Thanks all the teachers for the teaching, for giving our mistake. Then we learn from it and we go forward and improve our result. Thank you so much.
Thank you very much, Professor Zhang. I think the reconstruction tools are all very important to a reconstruction surgeon, because sometimes we feel one tool is kind of insufficient or cannot improve all the aspects of deformities. So we really need multiple tools to accomplish the reconstruction job. And as we can see that many surgeons, we are quite afraid of the fat injection could have some possible complications, especially when we inject to the facial part surrounding the eyes or near the vessels. So do you have some standard strategy that can let our surgeons not so be afraid of the complication?
Yes, as I mentioned that the Dr. Coleman published, Dr. Coleman published on 2002 avoidance arterial occlusion. We know that the nasal dorsum is more dangerous, and the periorbital area is more dangerous areas for intravascular injection. And we know that the vascular, the diameter is almost less than 1 millimeter. And if you use 18 gauge is roughly 1.2 millimeter of diameter. So it's difficult using a large brown tip cannula to enter the artery and injection inside the artery. And I think the brown tip has lateral opening. So the fat will come out with lateral intrusion. Moreover, if you use mouth gun, every single push is 1/60. So the intrusion pressure is low. Unlike you use a hand, if you push 1 cc, you can roughly very quickly push 1.2 or 0.3 millimeter of fat, and the pressure is higher. So I think brown tip, small amount every passage, and the large caliber of the cannula, this can avoid intravascular injection. So if you can see lower, how does the injection field cause blindness? Because you're using small sharp tip cannula, especially periorbital and the nasal dorsum area. So right now, if I do the hyaluronic acid injection, I do not use 30 gauge. I use 27 gauge brown tip, or bigger. We have 21 gauge brown tip, and we have also 18 gauge brown tip. So I think brown tip is better than sharp tip, and the small passage. Every time you pass, fill in the space. Don't fill up a bolus, because all the complications come up with the bolus. Thank you.
Thank you. And another thing is that you mentioned a lot about the fat could coming down over the cheek area. My question is that, do we have some standardized protocol? For example, we could inject the upper area, and after a certain period of time, we just do some secondary procedure to avoid the drooping. And whether this kind of fat drooping is happening over the other area of the face, such as the nose or periorbital area, and why the situation we usually just see over the cheek area.
Because you know, if you calculate the amount here, I always inject. This area is more than 20 millimeter, and the 20 millimeter extra fat, the gravity will pull, because the suspension ligament will not hold on so much weight. For the nasal dorsum, it's not drooping. Initial after the surgery, this gentleman has slightly injection. You can see, you can pull the nasal tip down. This is not a drooping. you can notice right away after the injection, because when I inject, I always pull the nasal tip down. So this is not drooping, and the patient will like that because after the surgery, the patient will has less nostril show because you pull the nasal tip downward. So I think the fat injection drooping is only right now. I only notice for cheek. It's not happen for the temporal area, not happen for the medial cheek. I think it's only for lateral cheek. And I think that's because too much. And if you gradually inject once, twice, the same effect because you don't have extra ligament support. You don't have extra bony support. And the gravity is there. And it's like the patient, if gain fat, we always has extra fat coming up from the lowest part because of the gravity. So I think if you have extra part, someday it will drooping. So I think you will advise that you inject higher overlateral cheek compared to the normal. If the augmentation is more than 3 or 4 millimeter. If you want just 1 or 2 millimeter, I think 5 cc, 10 cc still okay. But more than 15, I think you should avoid injecting just adequate. You should inject higher.
Thank you. And is there any question or comments from the audience? Professor Ray Chang?
Yes, I want to congratulate Frank, Dr. Professor Chang, that you do quite a lot of things which I cannot or I do not dare to do. And especially something that you advise that number one is improve the scar. Number two, improve the cosmetic cupid's bow and philtrum column. The third is Professor Lowe's idea of reduction of the normal side to match the deficient side, which is a hemifacial myxomia or the other asymmetry, and you can make more symmetrical face. I think in our Craniofacial Center now, we do have the basic technique of bony reconstruction and some bony reduction, and then autogenous graft or bone graft, cartilage graft, and then finally the fat. I think we combine all this together, we can be better and better. I think all of our staff that we learned from Frank that do all this concept combined together to have the best result that we can provide for our patients. So congratulations. I think that everybody learned your idea, technique, and then all the concept that we can improve our results much better than I do before. Thank you.
Thank you, Professor.
Professor Law?
Yes, I would also like to thank Dr. Frank Chang that you focus on doing the fat injection therapy and also continuously improve the technique method and leading this technique in the department so that we all learn from you and then we all improve ourselves as well. Just as Professor Ray Chen lead us in the OGS technique, that I hope that you also set up so-called a standard protocol so that we can all follow, and in our center we can use this fat injection as a technique or as a weapon to improve our treatment result. But I do have a question that I hope you can answer. That is, in our daily practice, we always do slightly overcorrection. For example, 20 to 30% overcorrection. However, I also acknowledge that there's a concept that that people do normal correction. I think the idea they mentioned is that overcorrection can increase the pressure and then increase the fat necrosis. So anyway, the fat injection should always be repeated. So do not do overcorrection. Instead, normal correction. What is your comment on this concept?
Thank you, Professor Low. First of all, I like to thank you a lot because I learned a lot of concept from you also. And I am grateful I am here in this center. We all learned the orthodontic surgery from Professor Yurei Chen. I think from your questions, I think in the face, overcorrection is still desirable because the concept of overcorrection cause extra pressure and decrease the survival rate is mainly on the brace surgery. In the brace surgery, if you notice that every time the fat injection is not like our face, 10, 20. I think in my past experience, the maximum of fat I injected was 70 millimeter is the maximum for the whole face. But in the breast, each side either you come from 200 and 300. And from the experience of breast augmentation, you feel the pressure until once that reach the maximum is tenderness, almost no elasticity. After that point, the survival rate became lower. And in face, it never happened like that. We even inject 60, 70 millimeter over the entire face. You still can feel some elasticity because the face, you don't need like a 200 millimeter of fat. So that I still use 20% overcorrection. That's because my previous study, the survival rate range from 75% to 25%. And I noticed that 20% will always go away. So there's no overcorrection in any of my cases. I think 20, 30 is reasonable. More than that, if I have the better survival rate, 25%, if I overcorrect, you will find out a little margin that is ugly. Over volumization is harmful. So that I still advise over injection 20%. On the breast, never pass the limit because the survival rate will go downward a lot. Thank you.
Thank you, Professor Chang. Is there any further comments or questions? Indeed, the fat grafting is a very powerful tool for our patient with craniofacial deformities, and also it's a very delicate and meticulous technique, including the detailed numbers, because every part of the face, the injection skills are different, and the amount of injection, how much percentage of overcorrection. So we have a lot to learn from Professor Zhang, and hopefully we can improve our personal skills and help our patient. If there's no further question or comments, we close the meeting this morning and hope to see you next week. Thank you.
Thank you. Thank you.
Thank you.